Hi, I'm Steve Charles. I'm a vitreoretinal surgeon in Memphis, Tennessee, and I've been working with Orbis for some 30 years with all three of the airplanes, and I'm delighted to participate via this wonderful vehicle of CyberSight. I want to welcome Hunter Cherwick back to Orbis plane and the Orbis enterprise, and we're so delighted to have this opportunity. I'm going to talk today about everything from straightforward retinal attachment to the most complex, giant breaks and PVR, and sort of a cohesive approach to that. There's several themes that I want to cover. In the first section, the core theme is that there's too much scleral buckling going on. We have a cataract surgery community that produces patients that have very little refractive error, very little pain, no ptosis, no strabismus, and we cannot accomplish that with a scleral buckle. And yet, numerous people use ridiculous terminology like, it's the gold standard, we've always done it, it works for me. And they make comments like, well, of course, vitrectomy causes cataract. Not true, not true. Vitrectomy causes progression of pre-existing cataracts. It's my strong view that vitreoretinal surgery should emulate the type of experience that today's refractive cataract patients have, or even standard non-refractive cataract surgery. There's also a notion of those who have moved to vitrectomy instead of buckling, or are starting to eliminate buckling combined with vitrectomy, that, oh, well, if it's a tough case like PVR or traction attachment, you must use a suture 20 gauge or you must use 23. Simply not true. 25 gauge and 27 gauge vitrectomy are optimal for everything from straightforward brachymatosis retinal attachment to giant breaks and PVR. There's no need to make larger wounds or somehow revert to older 20 gauge suture technology simply because it's a more complex retinal attachment. I am absolutely unaware of any data to support that adding a buckle to a vitrectomy improves outcomes. Even numerous experts in the field use phrases like, well, it supports the vitreous space, or I just feel more comfortable. I've always done it that way. I do numerous PVR re-ops for other surgeons, and very commonly the PVR and the retinal breaks are posterior to a very broad encircling buckle. So what does the patient want? The patient wants a white, pain-free eye without sutures. They want no surgically induced refractive error. They want no double vision. And they want a procedure that can last 30, maybe 45 minutes under local, not 2 and 3 hour, 4 hour procedures that I see many vitreoretinal surgeons doing. So again, let's move forward to 25, 27 gauge minimal invasive vitrectomy and advance our techniques so that we can repair retinal attachments without adding a buckle or without doing a buckle. What about the advantages of 25 and 27 over 23? There are no disadvantages except this tool flex issue we'll all address. But what are the advantages? There's less pulsatile vitreoretinal traction. It's not just about less wound leaks. It's not just about easier access to small spaces because the tip's smaller. It's not just about more comfortable, all of which we've proven in randomized trials. It's about the fluidics being better, not worse. We had an era of about 5 or 6, 7, 8 years where people said, oh, well, 23 gauge is better because it has higher flow rates. And they use terms that are simply inappropriate from a physics perspective, like flow efficiency. There is no such thing as flow efficiency. Those are separate terms. There's flow rates, which is a number like cc's per minute. And there's efficiency, which is how much material, vitreous and tissue that you remove per unit of infusion fluid. And that has nothing to do with the machine. That has to do with technique. So let's move forward to some of the issues. With respect to vitrectomy, what are the success rates of primary rhegmatitis retinal attachment? They've been reported as low as 75%, but good surgeons are achieving roughly a 90%. Once again, there's this notion that it causes cataract, and therefore phaco-vit is excessively done worldwide. There are numerous surgeons believe that if you're 20 years old and they decide to use vitrectomy to repair attachment, they've got to do phaco and remove your lens. Patients like to accommodate. They can accommodate till they're 40 years old or so. There's zero evidence that you induce cataract when you use today's small fluid volumes to go through the eye and today's advanced infusion fluids like BSS+. The incidence of endophthalmitis is extremely low. I've had 3 cases and now 38,000 vitrectomies. The last one was 25 years ago, and this was a patient that refused any antibiotics subconjunctivally after the procedure. The other 2 were diabetics. Then in retrospect, I probably shouldn't have operated because they had systemic infections. But what are the buccal complications? I hear people who advocate buccal, who in my view are living in the past, say, well, you know, I never see any of these complications. They're not looking because they're there. If you encircle, you're going to get induced myopia, and you're not going to be able to predict it or measure it. So let's assume the patient's had LASIK or is an effective contact lens wearer, and then you throw a buccal around the eye, as people say. You encircle the eye, and now they've induced somewhere between 2 and 4 diopters of myopia. They're not happy. They've had cataract surgery. Some effort's been made by the cataract surgery to get the refractive outcomes optimally, either monovision or hopefully your distance correction. And then the patient gets a detachment, which occurs after roughly 1% of all cataract operations. And now the surgeon elects to throw a band around the eye, encircle the eye, and induces myopia. Is there data to support induced myopia? Yes, there is. The late Ron Michaels and his fellow at the time sent all the patients that he was an elegant buckler, sent all the patients to the Wilmer strabismus clinic and had a really careful refraction, pre-op and post-op. Average 2.75 diopters of induced myopia. What about ptosis? I can commonly walk in a room and say, oh, have you had a scleral buckle in your right eye? Oh, yes, I have. Why? Because they've got a little ptosis. And my colleague Chris Fleming, who's an ophthalmic plastic surgeon that's worked with Orbis quite a bit, tells me it's probably damage to the levator aponeurosis. What about strabismus? Again, the late Ron Michaels, back in the late 80s, and I think in 1990 possibly, sent all the patients to the Wilmer strabismus clinic and had their forias and tropias measured. 50%, he was, again, a very meticulous scleral buckler, very careful with the tissue. 50% of the patients had increased forias and tropias. Patients are not happy with double vision. Today, we learn more, there's more and more emphasis on ocular surface disorder, sorry for the spelling error, and we've learned that ocular surface disorders are not just about discomfort, they're about a visual disturbance because the first optical element in your eye is the tear film. So I noticed that many scleral bucklers will put 1 suture at 3 and 1 at 9 and pull the conjunctiva up so there's a ridge or even overlapping the peripheral cornea. That disrupts the tear film and is going to cause Delin and cause discomfort and cause blurred vision. Persistent subretinal fluid has been shown to be more common in scleral buckling cases than it is in vitrectomy cases. Buccal intrusion, infection all occur. I've removed many buckles over the years, some that I put in the earlier years. I haven't done a buckle in 12 years. Others put in more recently by others. So with all careful technique of covering the conjunctiva, covering the buckle with not just conjunctiva, but with Tenon's capsule, suturing it properly, being careful to properly imprecate the buckle, there are still extrusion rates. Why? Because the tension on the sutures causes them to cut or cheese wire through the sclera, particularly in Marfan syndrome or myops with thin sclera. When the buckle then makes a convexity in the conjunctiva, again, the tear film is disturbed and they develop a Delin over the surface of the buckle, causing the patient to have an extrusion or an infection, particularly if it's a sponge. Retinal incarceration occurs up to 5% of patients with conventional drainage. That is not good, not to have retina incarcerated in a drain site. And there's also bleeding that occurs at the cut down drainage site. But if you have a large detachment and you try to do it in a non-drainage, you have the problem of elevated pressure. Again, vit buckles, what are the problems? Longer operating times, all the issues and a higher incidence of the use of general anesthesia, which increases morbidity, potentially even mortality, and certainly cost and discomfort. And again, there's no evidence that adding a buckle to vitrectomy improves outcomes, even though numerous very experienced surgeons remain advocates, even though I'm trying to push our whole community of vitreoretinal surgeons in the other direction. So what are some of the enabling technologies and techniques that allow us to get rid of the scleral buckle and repair these patients with retinal detachment with vitrectomy alone? I've alluded to 25 and 27 gauge vitrectomy. But much higher cutting rates make a difference as well. We're now in the 7,500 to 10,000 cuts per minute, and we actually have FDA approval on the language reduced pulsatile vitreoretinal traction. That's a big deal. Fluidics used to take up to 2 seconds to respond to a foot pedal command. Now they're in the 50 millisecond range. We now have sutureless vitrectomy techniques, both in 27 and 25. Wide angle viewing is essential. Rubens Belfort first introduced contact-based wide-angle viewing. Manfred Spitsness first introduced the non-contact. So now we have both various wide-angle contact lenses, as well as Biome and Resight, IVUS, and other non-contact viewing systems. I have been historically a big advocate of contact-based, but yet 70 to 80% of the surgeons use non-contact viewing. I now have revisited that and beginning to combine the use of contact lenses and the non-contact systems as advocated by several of our colleagues in Japan. And I emphasize once again this notion that de novo cataract is not caused by vitrectomy when you use appropriate infusion fluids like BSS Plus and keep your operating times and therefore fluid throughput in the eye reasonable. If you put a liter of fluid through the eye, you can get a posterior subcap, but not nuclear sclerosis. Well, why do patients get cataract? Why do they get nuclear sclerosis advancement after vitrectomy? That occurs because, as Nancy Holkamp has shown, when you remove the vitreous, Einar Stephenson has taught us that you reduce the viscosity about 900-fold, and therefore diffusion of oxygen, think Fick-Starling principle, can occur at a greater rate. And Nancy Holkamp has shown that the partial pressure of oxygen after vitrectomy permanently increases by about 12 millimeters of mercury, and nuclear sclerotic cataracts are known to be an oxidative reaction. But if you have no nuclear sclerosis, it doesn't produce it. I have numerous patients, hundreds and hundreds of patients that are 20 years, even 30 years out from vitrectomy that still have a clear lens. What's the trick? They were 18 years old, 20 years old, 30 years old, and had a clear lens when we started. And so we have to get rid of this notion that, well, vitrectomy always causes cataract, therefore I do buckles. I've heard it 1,000 times on the podium. It's wrong. Put it behind us. I'm not going to review these references, but I want to make the point that, yes, I've done 38,000 vitrectomies, but that doesn't make me an expert on everything. So I've reviewed carefully the literature, looking at the success rates and looking at these various complications. And there's quite a few papers in the literature to support vitrectomy repair. There's a wonderful paper by Pericles Brasilikos from Greece, who trained with Don D'Amico at Cornell. Elegant paper showing slightly higher success rates with prior vitrectomy. The paper from a multi-author, multi-center study from Europe that purported to show that the buckles were better than vitrectomy in some instances was a very flawed design where the doctors could change techniques, and that paper's often referenced, but in my view, in error. If you look at specific complications, the papers are out there. Many years ago, Fison published this, as you see, 311 patients. Papers on extrusion are out there, infection requiring explantation of the buckle. And again, there's this Michael Smitty paper I alluded to about the 2.75 diopters of myopic shift. I happen to use the Alcon Constellation Vision System. I use the standard endo illuminator. I don't have a problem with the chandelier, although it is another wound. Of course, I'm careful to make scleral tunnel sclerotomies, which many refer to as bevel, which is inappropriate terminology. As I said, I'm transitioning from using contact-based wide angle to now using non-contact viewing combined with a contact lens, an idea that came from our colleagues in Japan. The crucial elements are, one, never pull back a cutter while the cutter's operating. If vacuum is applied, don't pull back. There's too much aggressive PVD creation with induction of retinal tears, and we'll talk about that more in a moment. It is absolutely essential not only to excise the flap of horseshoe tears, but to remove the vitreous anterior to all of the retinal breaks. That obviously means it's a little more peripheral, and one has to be careful not to bump the lens in a clear lens eye. But again, we must try to remove the vitreous 360. Sometimes scleral depression could be very helpful there, but often if you use proper wide-angle visualization, you can do an excellent peripheral vitrectomy without the need for scleral depression. What are the options to reattach the retina? In standard rhegmatogenous retinal detachment without giant breaks, without PVR, I normally do not use liquid perfluorocarbon or perfluorocarbon liquids unless there's fogging of the IOL because there's been a YAG laser capsulectomy. When you do a YAG laser and you disrupt the anterior face, now the air bubble in the vitreous cavity can have contact with the lens. Of course, silicone lenses have a lower index of refraction. They're thicker and therefore a greater thermal mass, and therefore they store cold and causing the condensation to be worse. But the condensation also occurs with PMMA as well as acrylic lenses. It's not limited, as some people think, to silicone IOLs. So in short, I will use PFO to reattach the retina only in the instance of fogging of the IOL, as we just discussed. I'd use confluent laser around the tears, but I never use spots. Why do I use confluent laser? When you have a thermal laser energy that you're using to create thermal energy, so light to create thermal energy, the heat cannot diffuse out of the center of the spot as effectively as it can out of the periphery of the spot that you create. So in short, every laser spot is much hotter in the middle or in the center than it is on the periphery. But if you move the laser while it's being applied, you smear it, if you will, so now there's a uniformity of the burn. If you use spots, you have two choices. You could overlap them, in which case it's too hot in the overlapped area, the burn is too intensive, or to make a term up, you can underlap them, in which case there's a gap in between so that subretinal fluid can travel through. So in short, so-called painting, well, a much better term is confluent laser burns, are far preferable, and I've always used that. And they need to be relatively light burns. You don't want to cause full thickness necrosis of the retina or excessive inflammation. If I use gas, I no longer use C3F8. It's simply too problematic for the patients to have bubbles lasting 3 to 4 weeks. So I always use SF6. Although it's off-label in the United States, and it certainly can be used, I leave not fluorinated silicones, not Denseron 68, not oxane, but PFO, the N-perfluorooctane alkynes for fluoron. I leave it in for 2 weeks for inferior detachments. I have a series dating back over 20 years now, hundreds and hundreds of patients, approximating 1,000 now. It is absolutely, unequivocally not toxic. It has 2 issues. 3. 1, you got to remove it 2 weeks out. 2, residual bubbles must be removed. And 3, some patients have transient inflammation that goes away, but we'll talk more about that later. Wide-angle illumination is important, but there's a bit of a trade-off here. If you have too wide-angle, and you have an IOL in the eye, there tends to be more glare because of this backscatter. So I'm not a big fan of the bullet or chandeliers for routine cases. I normally use the standard endo illuminator so that I can do focal, specular, and retro illumination. What do I mean by specular? That's the way you inspect the surface of something shiny like an automobile to make sure there's not some little defects. And that's the best way I can describe it. And that's the way you can find rather transparent membranes on the retinal surface, or even find subtle areas of subretinal fluid you might have missed with wide-angle illumination. So instead of illuminating everything like a fog like high beams in your car, you want to have a bit of a narrower beam that you can move around and use retro illumination, bouncing light off the vitreous cutter to visualize vitreous. And by doing that, it often eliminates the need to use Kinolog or triamcinolone to particulate mark the vitreous. So now let's talk about cases that are not routine rhegmatogenous detachments, but cases that are more complicated. And I use the term Retina, the reattachment experiment. But I've been asked quite a bit in the last 2 years about when do I do retinectomy. First of all, never do this under saline. Don't do it with infusion fluid eye. Always do retinectomy under air. And don't do it under PFO because you'll have a greater risk of having PFO or liquid perfluorocarbon droplets under the macula, which is not a good thing. So what I routinely do is to do the reattachment experiment. So let's tell what I mean by that. First, in every detachment case, and especially in PBR, you must resect, as shown here, the anterior loop traction. These are radial fibers, radial vitreous fibers that used to be in contact with the retina. They're now contracted because cellular elements cause contraction of these collagen fibers. When people call this peripheral vitreous membranes, there is no such thing. Membranes never grow anterior to the posterior edge of the vitreous space. This is vitreous, not a membrane. And they're not peelable. And to call it shaving is a bit of a misnomer as well. So what really are we talking about? We're talking about there's three sort of orientation of fibers. Fibers that run across the eye, the equator to equator, I call them frontal plane. In PBR, there is no core vitreous. There's a confluence of the anterior and posterior vitreous cortex in this frontal plane. Everybody knows to remove that. But there's no real core anymore. It's a sheet of confluence of the anterior and posterior vitreous cortex. Then there are fibers that run in a circle at the posterior edge of the vitreous space. They're highly adherent to the retinal surface and virtually impossible to peel without tearing the retina. But then there's these fibers demonstrated in this graphic from my colleague Byron Wood. And these radial fibers I call anterior loop traction. Those must be resected in every detachment, but clearly in PBR when they're contracted. When cutters were 20 gauge, I had to do this with the scissors. But now that the cutters are 27 or 25 gauge, there's almost invariably enough space where you can get in there. And if you're more peripheral, you're actually less likely to catch retina because the retina, you might say it's on a short leash. There's not as much slack in the retina anterior to the equator. So try to get real anterior. You might have to use scleral depression if there's posterior cortical cataract, posterior capsular cataract, or capsular opacification after cataract surgery. But I don't use scleral depression as much as some other people do because the wide-angle visualization gets around that. What about if there's subretinal proliferation? If it's clear that it tints up the retina, you don't need to make a big retinectomy to remove it, and you certainly don't need any diathermy. What I do is go to the place where the membrane is the band under the retina is the most taut, close the forceps, the max grip forceps, and simply punch through. So I call it punch through retinotomy. Then I back off a little bit, open the forceps, and grasp the membrane. And I use the endo-illuminator like a second tool to hold the retina back as I pull this string out from underneath the retina, as depicted here. On occasion, you can pull such a great length of membrane that you can use the endo-illuminator like a pulley and pull it over the end of the endo-illuminator and get double the pull length. You got to be very careful if these membranes, these bands extend posteriorly to observe the macula. There's a tendency when you make video to look at your instruments and focus on where you're gripping the tissue, but that doesn't matter. It looks pretty in the video, but it isn't. It's not where the safety issues arise. The safety issues arise by not paying attention to the macula. So I have seen cases where people were very proud to pull out a membrane only to realize that the membrane went underneath the macula and they made a tear right in the posterior pole. So keep your eye there. So this sequence here is the most important single thing we can talk about other than elimination of scleral buckles and moving to all 25 and 27 gauge vitrectomy to repair retinal detachments. So what's the sequence about? We all know to do the vitrectomy and eliminate tear in the flaps first in any detachment, rhegmatogenous or rhegmatogenous combined with PVR. Then you start a procedure I developed over 42 years ago, internal drainage of subretinal fluid. People often use a misnomer. They say, I use air to flatten the retina. Air doesn't flatten the retina. You have to drain the fluid out somehow. And so I invented the notion of draining through the retinal brain. So you first initiate draining. Then when the retina stops moving back, you turn on the air. And the air acts as a surface tension agent to kind of seal up where your little drainage cannula goes through the break and to seal up all the additional tears so you don't just recirculate fluid. And some people call that fluid exchange. I don't know why to call it that. It's internal drainage of subretinal fluid, draining through the break. So then you turn on the air level goes down until it kind of seals up all the breaks, and if it's a rhegmatogenous detachment, it gets attached. But if, as it starts going back, it gets hung up, it won't move anymore, or even a little air bubble appears, that means there's traction. So first inspect and see if there's vitreous traction. And if there is, if you've missed a little vitreous traction, then you can do vitrectomy under air. So implicit in my retinectomy technique, as well as in other complicated settings, is the notion of vitrectomy under air. And we'll generalize that notion as we proceed through this presentation. So let's assume now the retina moved back, you found a little vitreous, you did vitrectomy under air, being careful because the vitreous acts like a bit of a lens element and it can kind of be a bit deceiving about where the tip of your instrument is located. So then you transition to the membrane peeling under air. Often if they're two large bulla side by side, you won't see a little star fold hidden in the valley between the two bulla, the two convexities. So as you continue to drain fluid, the retina starts to go back. If you see a membrane, don't stop and put Kenalog, triamcinolone in the eye or PFO in the eye. Simply peel the membranes under air. The only time you can't do that is if there's IOL fogging or if it's an aphakic eye with striate keratopathy from hypotony or from a corneal laceration repair. But in most instances, you can do it. In those patients, simply go ahead and put oil in the eye and do this work under oil. Carl Kleiss has taught that, and it's an excellent technique. So once again, the retina starts moving back, it hangs up, you do vitrectomy under air. It moves back farther, it hangs up. You peel membrane. It moves back farther, it hangs up. You remove the band. Again, under air. Then and only then do you say, oh, well, the peripheral retina is too contracted. I've eliminated everything on the front of the retina that I can take care of. I've even eliminated a band. I guess I have to cut the retina. So that's the crucial time to do retinectomy. If you do, so this just illustrates in text that sequence. Removal of the frontal plane vitreous, as I described, the confluence, the anterior posterior vitreous cortex, the radial fibers, anterior loop traction, and then forceps membrane peeling, removal of significant subretinal bands accessed by punch-through retinotomy, internal drainage subretinal fluid, as I said, prior to fluid-air exchange. That's the sequence. You continue the drainage, you research for residual vitreous, residual membrane, residual subretinal, then you start this incremental retinectomy. What do I mean by incremental? People say, well, how much do you know to do? If you do it under saline, I don't know how much to do. That's why I don't do it under saline. What I do is to cut enough till the retina reattaches. But if it required going to 270, I go ahead and take it to 360. Usually it's inferiorly in PVR, and so I tend to carry at least a little bit above the 3 and 9 o'clock meridian. So once the retina is attached, then careful confluent laser to the retinectomy edge and severed large vessels. I can bump up the pressure if there's a bleed from the vessels. I normally don't use diathermy. And again, this eliminates the need for a buckle, and we've discussed the disadvantage of buckle. What are the advantages of retinectomy under air? Well, for one, you do the correct amount of retinectomy. Not too little, not too much. Second, the retina doesn't jump around. It's stabilized. Thirdly, if you choose to do it under PFO, it's real easy. Every meeting I go to, somebody discusses how to remove PFO from under liquid reflorocarbon from under the macula. My answer, don't put it there and you won't have to remove it. And then if there's a bleed with air in the eye, it confines the bleeding to the area of the break. It doesn't diffuse the vitreous cavity and destroy your view. So this shows you the major difference between what Makamer recommended, which was relaxing retinotomy, and what I recommend, which is retinectomy. My retinectomy technique and his circumferential relaxing retinotomy technique were developed at the same time and independently. What's the difference? He just made a circumferential cut and left all the tissue anterior. This results in a higher incidence of anterior segment neovascularization because VEGF is released from this ischemic peripheral retina that's been removed from its blood supply. It results in a higher incidence of hypotony and ptysis because of epiciliary tissue, and I believe it has a higher incidence of PVR recurrence because of seeding of the cells that are stored in this vitreous base area. So in short, it's about retinectomy, not Makamer's technique of relaxing retinotomy. So this then illustrates all these points in text-based fashion in case you didn't catch it when I was talking in front of the slide. This anterior segment neovascularization issue is quite interesting. Harry Flynn talks about donut detachments, and this is from people that do 360 laser, but they make a row posterior to the equator or right at the equator, and then all the retina anterior to that remains detached. That's a bad plan. You've got to get all the retina attached because that peripheral retina, as I've already mentioned, will elaborate a vascular endothelial growth factor VEGF, which results in anterior segment neovascularization. I've had to go in other people's cases and a few of mine where we had the so-called donut detachment and excise all the peripheral retina in order to cause the iris neovascularization to go into remission or regression. So let's generalize this concept of vitrectomy under air. What do I mean? I call that interface vitrectomy. So people say, well, you can't do vitrectomy under oil. Sure you can, but you can't do it in the oil, hence the term interface. So if you're always operating in the vitreous space, the retinal space, the subretinal space, so you can do retinectomy, you can do anterior loop dissection, you can drain subretinal fluid, all the techniques that work under BSS also work under air, oil, or liquid refluorocarbon. Anterior loop removal, forceps membrane peeling, scissor segmentation, delamination that you do in diabetics, punch-through retinotomy for subretinal surgery, retinectomy, all work under air. We all know we can laser retinal breaks under air and drain fluid under air. We do it every day. But many people forget all these other techniques work not just under air, they work under oil or under PFO. I use medium-term PFO for inferior attachments. The patient can sit up, stand up, go to work, drive a car, fly in an airplane, and the PFO stays in 2 weeks. When I put the PFO in after I thought I removed all the vitreous traction, on occasion, I'll see vitreous that's outside and therefore anterior to and peripheral to the PFO bubble. And by carefully sticking the cutter in there, I can remove that and then top up the PFO and remove further traction of the PFO. But I do that once the retina is largely attached, so I'm not going to get PFO under the fovea, and I'm certainly not going to use that PFO technique in PVR. So what are the advantages of interface vitrectomy? 1, improved visualization of residual vitreoretinal traction. 2, subretinal fluid remains stable or decreases as you work, as you remove the traction, instead of the retina moving around and having high mobility of the retina and having fluid accumulate and increase. So this dampening of retinal motion is a big advantage of interface vitrectomy. And as I mentioned earlier, you also confine any bleeding to the retinal surface or right to the interface. So what's the basic technique? Always keep the cutter port in the fluid or in the retina membrane complex outside the interface between the fluid and the surface tensioning. That way you don't lose the PFO or oil, and you don't plug the cutter with oil if you're doing reops under oil. So I'm going to speak about this further, but every time I use oil for PVR, if they develop an epimacular membrane or if they develop recurrent PVR, I re-op them with oil in the eye, and it works very, very well. You've got to use max vacuum, 650 millimeters of mercury on the current machines. And again, 25 and even 27 gauge technique works. You can't put a 27 gauge cutter in oil and turn it on and expect it to not plug. And even the 25 plug as well. But that's why you work at the interface. Again, always staying in the aqueous/tissue phase, not in the oil phase in the vitreous cavity. So if you look at the agents, what's different about them? So they're all, by all, I mean air, oil, and heavy liquids, all immiscible in water. Well, two of them float, oil and air, and one of them, PFO, sinks. So that's a specific gravity consideration. The specific gravity of PFO is roughly 1.8. It's nearly twice as heavy. That provides 2 forms of stabilization of the retina. One is because it's twice as heavy, almost twice as heavy, it actually puts a gravitational force in the retina. It literally presses the retina down. And that helps express subretinal fluid through the retinal breaks. It literally is a gravitational force issue. But then remembering F equal ma, the force equals the mass time and acceleration, there's also what I call inertial stabilization of the retina when you have heavy liquids in place. With air, it's a spring damper, like a shock absorber in your car. But with silicone oil, it provides viscous dampening. And in fact, many shock absorbers in the car have both the compressed gas as well as oil to slow down the oscillations. So what are the clinical scenarios in which I use interface vitrectomy? One is residual vitreoretinal traction noted during fluid air and internal drainage of subretinal fluid. That's the reattachment sequence I just alluded to. Another one is residual vitreoretinal traction noted after the PFO is injected. A third one is excessive movement of the retina during with saline in the eye. If the retina's jumping around during vitrectomy, put air in. It'll keep the eye from jumping around. And if there happens to be an aphakic eye with stride keratopathy or a corneal laceration that obscures the view when air interfaces with the back of the cornea, fill the eye with oil and you'll see better, and you can go ahead and continue to operate with oil in the eye. And then if you put PFO in and the retina starts going back and it hangs up, just like I described with air, you can remove some residual traction. And then lastly, and I've already mentioned this, I do all silicone reops under oil. But here's what I hear about around the world. People say, well, it's the PVR came back, so I took the oil out, I put PFO in. Well, there was a little PFO under the fovea, and then I put an additional, a big buckle around the eye, and it took about 3 hours, and then at the end I put the oil back in. Why? Why do that? Why put the eye through that much trauma and induce inflammation and uveitis and even exacerbate PVR? What do? If you got oil in the eye and you PVR recurrence, peel membrane under oil, do retinectomy under oil, drain the fluid. It takes 2 ports only. Typical reoperation time, 20 minutes. PVR under oil, 20 minutes, maybe 25, instead of these 3 or 4 hour pain-producing procedures. The interfacial tension agents, you can see there the difference in specific gravity and viscosity. The viscosity of water, of course, is 1 centistoke, and oil is either 1 or 5,000 times as much, and PFO is actually less viscous than water. So the most important point in this slide is I've had people say, how do you do PFO with small gauge incisions? It's less viscous than water, not a problem. You can put it in a 30 gauge needle. So what are the advantages of air? It's free. It's easy to inject and remove. It has the highest interfacial tension. What's the disadvantage? As I said, IOL fogging or stride keratopathy. And this makes the spring dampening point of air. What about PFO? 2x inertial dampening, 2x gravitational downforce. It's very easy to inject and remove, less viscous than saline. It's medium cost. Disadvantages, you have to remove residual droplets. The droplets it has modest surface tension, and the little droplets spin off the big bubble. Anytime I leave PFO in for 2 weeks, I fill it all the way up. That's essential to reduce the number of small bubbles. But still, little bubbles get hung up in the zonules, and they'll migrate in the anterior chamber. And we have a nice technique that my partner, Stephen Huddleston, and I reported about how to remove the little droplets in the anterior chamber with 2-needle technique in the office. So the PFO, as I said, supplies both inertial and gravitational dampening of the retina. So if you have PFO in the eye, you can do some removal at the posterior edge. This illustration doesn't quite show that very well, but in short, it is possible to carefully avoid removing the PFO and remove residual traction. And finally, interface vitrectomy with silicone oil. If you're going to leave oil in anyhow, why not see if you can attach the eye under oil, not under air? So here's a common scenario that I've experienced, we all experience. You do vitrectomy, complicated retinal attachment with PVR, you get the retina reattached under air, you laser the brakes, and then you do an air-oil exchange. And the patient comes to the office the next day, gosh, there's a little inferior attachment. What did I do wrong? It was attached at the end of the procedure. What you did wrong is forget, and I've certainly done this more times than I care to remember, is you forget that the surface tension of fluid air is about 70 dynes per centimeter, and with oil, it's about 42. So in short, there's 50% less surface tension with oil than there is with air in the eye. So bear that in mind and make certain that you get rid of all the traction. But if you operate under oil and the retina is attached at the end of the procedure under oil, you're much more likely to see an attached retina the first post-op day. And so here's that viscous dampening point I made before. So these scenarios, I'm sorry, that's a repeat slide. So what about this 2-port technique? If you have a retinal detachment and oils in the eye, or if you have an epimacular membrane, I put 2 ports in the eye, not 3, no infusion fluid. I don't use tubing connected to the VFC. I simply have 2 ports. If it's an epimacular membrane, and I'm using valve cannulas, you don't remove any oil, and therefore you don't have to add any oil. You don't even have to open the oil and save costs. You simply put the ILM forceps in there and peel the membrane. You got the endoilluminator in one hand, and you've got the forceps in the other hand. Now, if it's PVR and you've got to remove subretinal fluid, then what I do is I remove some of the subretinal fluid under oil. The eye gets a little soft. As the Brits say, I top up the oil with the VFC by taking the cutter out of the port. And of course, the oil doesn't run out like saline would. The eye doesn't get soft. And then I reinflate the eye. Then I remove a little bit more subretinal fluid. It might take 3 or 4 iterations like that. But then in a 2-port technique without infusion tubing even connected, you can re-op a PVR case under oil. It works very nicely. It's a very quiet eye. So here's silicones in the eye, and I'm peeling a starfold under oil, or peeling, in this case, an epimacular membrane. And this shows me in the right side topping up the oil at the end. And these are the older type of cannulas depicted there. This medium-term PFO concept I'm very pleased about. As I said, there's a series in Australia and New Zealand. New Zealand started about when I did. They certainly didn't learn it from me, but they do a lot of these cases and are very happy with it. And many people are getting back to me now that they're using this technique and very happy with it. So what are the key elements? Well, as we know, if you're doing even macular hole surgery, that the interaction of the bottom surface, the inferior surface of the bubble with the inferior vitreous can cause an inferior retinal break. This certainly happens in pneumatic retinopexy as well, or just superior detachments. So in short, if you learn that lesson, that if you put something in the eye that floats, you got to be careful to remove all the vitreous inferiorly because of where it interacts with the surface of the bubble. Well, when you put PFO in the eye and leave it for 2 weeks, it sinks. So now you got to be very careful to remove all the vitreous superiorly. So again, the case is remove the vitreous 360 in every retinal detachment case, but not in macular surgery cases. There's excessive peripheral vitreous shaving going on in macular surgery cases. There's simply no reason for it, and it increases the chance of damaging or bumping the lens. So back to this technique of medium-term PFO. Do a vitrectomy. Let's say it's a young myope and they don't have a PVD. Don't pull on the vitreous aggressively and make a PVD and make other breaks. And don't say, oh, well, there's no PVD, I must do a buckle. No, put the PFO in. The retina will slowly attach right before your eyes. It might take 5 minutes for the viscous fluid, the viscous subretinal fluid to come out of the breaks. Occasionally, you have to apply a little vacuum to the breaks. Once the retina is completely attached and you've removed any apparent traction, again, no forceful PVD creation in these young myopes with lattice without a PVD. When you come back in 2 weeks to take the PFO out, it's not just an exchange. You put the cutter in and you will find that they have gently, slowly created PVD during that interval. It's really nice. Why 2 weeks? By then, the laser marks have maximum tensile strength and they're usually pigmented in. If you leave it longer, there's an increasing amount of inflammation from the PFO. It's not toxic. As my ex-fellow Eric Sigler has reported, it's a foreign body reaction. And when you remove it, any little white deposits on the retinal surface or the IOL, it goes away in a couple days without a problem. And again, you've got to remove it in 2 weeks, as I said, and you've got these residual droplets, which can be removed with 2 needles in the office, one to infuse into the anterior chamber from above, and one 27 or 25 gauge, 30 gauge needle inferiorly bevel up right at 6 o'clock, because of course this is heavy liquid, and you can remove the bubbles very carefully in the office, very safely, even in phakic eyes. We've done this many times. Currently, we're over 900 eyes. I give them topical difluprednate for 2 weeks unless they're a steroid responder. And again, we've got this procedure 2 weeks hence to remove the PFO. 360 peripheral vitreous removal has been emphasized over and over again by all of us that do these procedures. So here's the PFO filling. What do I inject? I use the Med1 dual bore cannula. I did not invent it. I don't have a royalty on it. The Med1 cannula allows balanced salt, illustrated here, to achieve egress from the eye, so that you have a normal tensive procedure. You don't have a tiny needle with a leaky port that you're injecting through in order to prevent increasing the interocular pressure. So this dual bore cannula is a very nice idea. So the so-called up port is the one that allows fluid egress, whereas the distal port, either the side or the tip type, is where the PFO is injected. But how should you do it? You should always have the tip of the cannula, the part where the PFO comes out of the cannula, in contact with the top surface of the bubble. So that means you got to slowly withdraw while observing the interface and raising up the focus in your microscope. That is crucial. Why? If you do that day in, day out, you can make a single bubble. When people say, well, in pneumatic retinopexy, I always have this problem with fish eggs, I make multiple bubbles. You did it wrong. If you lay the patient on their side and you barely put the needle in, you can inject slowly and make a single bubble in a pneumatic retinopexy. Similarly, when you inject PFO, if you stick a short needle in the top part of the eye, you're going to have a zillion droplets, and then you got to wait around for them to coalesce. And if you inject too forcefully, the jet could make a hole in the retina potentially. So the side flow dual bore cannula from Med1 works well, or just inject slowly over the nerve until you get maybe a 2 or 3 millimeter bubble, and then hold the tip of the cannula right in contact with that bubble and withdraw it slowly as the bubble increases in size, and you can create one single bubble. But you gotta really have sharp focus with the microscope. The interface has a very small index of refraction difference, and it's very hard to see. And it's even harder with fluorodecolon than it is with N-perfluorooctane. And so then confluent laser, as depicted here around the break, I know it looks like a smile and somebody that's been drinking a milkshake, but that's the confluent laser notion instead of spots. Get rid of the notion of spots. That's for cryo. So if you've got the PFO in place, as depicted here, and there's some subretinal fluid, you can do one of two things. You can drain it here just by putting a soft tip cannula or a tiny metal cannula through the hole. Or you can extend the break anteriorly a little bit, as depicted here, so you can get rid of the anterior fluid. You've got to get rid of all the fluid, and you got to be able to laser fluently around all the retinal breaks, of course. And this shows you the cannula that Med1 makes, which again, I did not invent. That is the end of my formal presentation. So now we can take any Q&A questions if you have some questions. Well, we don't have any open questions out there. So let's do this over the remaining 10 minutes or so, unless some questions pop up. Let's review what I've talked about. Number one, advance your techniques, challenge yourself to learn to repair every retinal attachment without a buckle. Implicit in that, learn to use medium-term PFO. PFO that stays in the eye 2 weeks for inferior retinal attachments, and what else? Giant breaks. If I have a temporal, a nasal, or an inferior giant break, I put the PFO in, I laser the whole extent of the giant break in a single roll with laser, and I let the patient lay on their back or reclining, and in 2 weeks, I go take the PFO out. I don't do exchange. Now, if they have a severe giant break, then I've got to exchange it for either gas or silicone, mindful of the David Wong technique that you must stay between the PFO liquid interface in the far periphery, so the meniscus is curved upwards, that it's convex, and you don't want to be at the apex of that convexity of the PFO bubble. You want to be at the periphery. So that's the point I want to make there. Let's get this out of the way. So I guess I was talking with my hands. So as the bubble is moving up like so, as you want to, excuse me, as you're exchanging it, here's the PFO bubble, and you're doing a direct exchange of PFO for silicone. You want to stay at the periphery of this convexity, because that's where the little meniscus of subretinal fluid, liquid vitreous, and infusion fluid is accumulated, and you want to remove all that so you won't get slippage of the giant break when you do an exchange. But so think about that. That's the inverse of how you inject PFO. You inject PFO by starting in the optic nerve head, making a small bubble, then withdrawing your cannula with the tip always aligned with the very top surface of the bubble as you grow the bubble and fill it up in a single. So always remember that it's central and on the top of the bubble when you inject, and it's peripheral on the outside edge of the bubble whenever you exchange for either gas or exchange for oil with the PFO. So this medium-term PFO technique I want to bear in mind. Another point we got to emphasize is don't think it's the tough case, therefore I must use 20 gauge. And don't think, well, I've got to support, it's a tough case, it's a PVR, therefore I've got to put a buckle. Change your mindset, try to put that behind you. If you look at it this way, do we today go to the operating room as if we're cataract surgeons and try an intercapsular cataract extraction? If it doesn't work out, switch to phaco? I don't think so. Do you try an RK, and if it doesn't work, then switch to LASIK? I don't think so. So why should you put a buckle in, and then if it doesn't work, go to vitrectomy? Learn to do vitrectomy properly, to get rid of peripheral vit distraction, to see in the periphery, to do these various exchange techniques, to operate under air, to operate under oil, to operate peripheral to the PFO, and then you've broadened your horizons, you've created a quiet, comfortable eye without refractive error. It's far better for the patients. And then the other point I emphasized early in my talk is the number of patients that I see that they did a phaco bit, but they had a little trouble with the phaco. The pupil came down. Now they had to use iris hooks, which induce inflammation and iris damage. Well, the pupil came down. I couldn't really see the periphery well enough. I had to do such and such. There's so many patients that have, for one, significant refractive error after phaco bit because they don't use the Warren-Hill's knowledge of formulas. They don't use aberrometry. They only use ultrasound to measure axial length instead of optical, low coherence optical means, which are far more precise because they measure from the pigment epithelium. And so we see refractive outcomes that are not good with phaco bit. The second thing we see is compromised vitrectomy because the phaco didn't go exactly as you'd hoped, and therefore the view is compromised. So what I tend to do, staged procedures. Patient presents with 2+ nuclear sclerosis. They need a vitrectomy to repair a macular surgery or retinal detachment. I tell the patient, you're going to need cataract surgery by a cataract surgery expert. That's not me. Let me fix your retina. In about a month, when the retina is stabilized and we're comfortable and the eye is no longer inflamed, a cataract surgeon will do a great job of refractive cataract surgery. On the other hand, the patient needs macular surgery and they've got 3+ NS or a posterior subcap. Cataract surgeon operates, you go back in a couple of weeks and do the macular surgery. Now, if you have a retinal attachment, you can't view, they can't have a significant view. Instead, if you're a really good phaco surgeon, okay, do phaco bit. But unless you're really good at it, there's no problem with lensectomy. And then once the retina's been attached for a month, do an anterior chamber lens. We've done many, many anterior chamber lenses. I'm very happy with it. I don't think it's absolutely necessary that everybody must have an intraocular lens in their eye in the capsular bag. So we have a question here about an anoretic patient who developed an RD after Ahmed valve surgery for ankle closure. I have not done this, but people have reported using sutures, a couple of sutures that go across the eye at the pupillary plane, where there would be a pupillary plane if there were iris in place, and it held back the oil. Some reliable people reported that. I don't have the reference in my head at the moment, but I think that's an interesting approach to try. I would not recommend this artificial iris approach. Those are very rigid, and I've had the opportunity to operate on a young girl that had this, and it was a huge challenge to do the vitrectomy. Now, what I've done in the anoretic patients is I just tell them don't lay on your back, and I've had good results with that. In a few anoretic patients, I've probably done 15 or 20 anoretic patients over the years. So if you just tell them don't lay on your back to sleep at night, lay on your side or face down, I've had some good results, and you can wait several weeks or months rather and take the while out at that point. Well, we don't have any other open questions, and we only have about 4 or 5 minutes left. And so, unless there's some more questions, let me provide my email address: scharles@att.net. Feel free to write me and ask me questions or comment on my talk. And I thank you very much for listening.
Dr. Charles, I've just put up on the screen some of the questions that were asked at the time of registration in advance.
Right.
Maybe just have a quick scan through those to see if there are any relevant questions or topics that you'd like to circle back on.
Sure. When was the last time I did a buckle? 12 years ago. Do I do a vitrectomy for inferior RDs in young faking patients? I do, and I use medium-term PFO. I use a wide-angle contact lens. I currently use the Vogue Avi. Not the Avi. I use the Vogue HRX ACS. The only problem I have with it is it fogs if there's high humidity in the room. I never use heavy silicone oil like Oxane or Denseron 68. A lot of info, for one, they're not approved in the United States, but for two, my friends in Europe that use them say it causes a lot of inflammation, and I don't do that. It says how does, okay, how do we manage liquid perfluorocarbons under the macula? I take a tiny MVR blade and make a slit over the bubble, a little tiny one, and the PFO will pop out, and then I'll put air in the eye, and that's all you need to do. If the patient reattaches with 360 retinectomy and oil, I'll peel membrane, even do further retinectomy if required. Prognosis total RD with MAC off. The patients have, particularly young people, have wonderful visual outcomes, particularly with vitrectomy. If you do a big buckle, it's a 3-4 hour operation, there's so much inflammation that the visual outcomes are not as good. So I've been very happy with doing vitrectomy only repair with MAC off and getting good visual results. How do I choose between oil, air, or buckle? I never use a buckle, so that one's easy. Oil is for a couple things. One is a patient that can't position at all, a patient that must fly, or PVR. I manage PVR re-ops under oil, as I said, by operating under oil. I don't understand that one. Oh, diplopia after buckles. This is the problem. If someone has a buckle in place, and the buckle's a high buckle in particular, and PVR, and the buckle's extruding or causing strabismus, if you remove the buckle, on occasion the retina will redetach because now the retina is, if you will, contracted in that new configuration. And so that's another okay, then another one says, what percentage of complex RD do I receive at institution? And when do I operate? I do around 800 vitrectomies a year. Many of those are macular surgery, but many of these are complicated, so-called complex retinal detachments, PBR, giant breaks, diabetic traction detachments. It says, do I have a protocol on when to operate? Yes, instead of rushing, particularly in a re-op setting, let the eye be quiet before you operate. The late Steve Ryan used to talk about the life cycle of PBR. Ron Michaels used to emphasize that as well. Operate on quiet eyes. What technique do I prefer? Giant retinal tears. You got to use PFO. If it's inferior temporal nasal, I leave the PFO in 2 weeks. Never use a buckle in giant tears. Never, never, never. And if it's superior, exchange it very carefully with the David Wong technique I just described. Exchange it for oil or exchange it for gas. Well, now it looks like I've answered all 17 questions and time's up. So thank everyone for listening, and feel free to get in contact with me via email if you have further questions.